Welcome to our Allied Lecdem channel. Today we are going to see about the cardiovascular diseases, a clinical approach. To evaluate a patient with cardiovascular disorder, one has to elicit a proper history. A patient may be asymptomatic and unaware of his underlying cardiac diseases. So, the common symptoms are dyspnea. Here, the subjective may feel difficulty in breathing and occurs due to passive congestion in the pulmonary veins and the pulmonary capillaries secondary to the left-sided cardiac failure. Dyspnea has been graded by the New York Heart Association into 4 grades in presence of the cardiac diseases. Grade 1, no dyspnea on any work. Grade 2, dyspnea on ordinary work. Grade 3, dyspnea while doing less than the ordinary work. And grade 4, dyspnea at rest. Orthopnea. It is the stage when a patient feels breathlessness while he lies flat and relieved by sitting up. It occurs within 1 to 2 minutes after assuming recumbency and recovery on sitting up. The major causes of orthopnea are acute left heart failure and extreme degree of congestive cardiac failure. Paroxysmal nocturnal dyspnea. Here, the patient gets sudden attacks of dyspnea during the sleep. This wakes them up and forces them to sit upright. The attack may pass off in a few minutes, and the causes are ischemic heart diseases, aortic valve diseases, and the left heart failure. Treponea and the platypnea. Treponea, here it occurs only in the left or right lateral decubitus position, where the platypnea which occurs only in the upright position. Cough. It is a voluntary or a involuntary act that clears the throat and the breathing passage of the foreign particles, microbes, irritants and the fluids. Cough of pulmonary venous hypertension is irritating, non-productive and worse at night. In some cases, such as dry cough occurring during the exertion, may first raise the suspicion of underlying cardiac diseases. In severe pulmonary venous hypertension and the pulmonary infarction, blood tinct sputum is seen, while in pulmonary edema, the sputum is pink and frothy. Pulmonary edema. It is a condition caused by the excess fluid in the lungs. These fluid collect in the numerous air sacs in the lungs, making it difficult to breathe. In most cases, heart problems cause the pulmonary edema. Peripheral edema. It is a swelling that is caused by the fluid trapped in our body tissues. It happens most often in the feet, ankles and the legs, but can affect other parts of the body such as face, hands and the abdomen, and it also involves the entire body. Important causes of the edema in the feet. It might occur due to the congestive cardiac failure, nephrotic syndrome, liver cirrhosis, chronic lymphatic obstructions, and due to certain drugs. Nocturia. Due to edema, the patient complains of the oliguria, which is like low urine output, particularly during the day. At night, due to the redistributions of the fluid, the patient renal perfusion improves and he gets the nocturia, with the result that the edema becomes less in the morning. Palpitation. Palpitation is the consciousness of the heart beating. This may due to an enlarged hyperdynamic left ventricle as seen in the mitral and aortic incompetence, or may occur due to the arrhythmias like extrasystole, sinus tachycardia and the paroxysmal tachycardias. Syncope. Syncope is a transient loss of consciousness due to impairment of the cerebral perfusion. In heart diseases, it occurs due to low output. There will be a cerebral underperfusion. Causes of syncope. It might occur due to taking certain drugs like antihypertensives or beta blockers, reflexes like vasovagal syncope, or a situational syncope like micturition syncope, deglutition syncope, and cough syncope. Fatigue. This is caused by the low cardiac output leading to poor blood supply to the muscles. Low cardiac output is due to defective pumping action of the heart, which is secondary to the myocardial muscle diseases, valvular heart diseases, coronary artery diseases, or even pericardial diseases. Cyanosis. Cyanosis refers to the bluish cast to the skin and the mucous membranes. It may be peripheral or the central. Peripheral cyanosis is restricted to the distal part of the extremities, that is, finger, toes, nails, and the tip of the nose and the ears. It occurs in the low cardiac output states with peripheral vasoconstriction. Whereas in the central cyanosis, it occurs in the mucous membranes and usually associated with the clubbing. The ants are warm in contrast with the peripheral cyanosis, in which the ants are cold. Causes. It might due to shunting of the blood from the venous to the arterial side at the ventricular, atrial, or the aortopulmonary level. Another cause of this central cyanosis is inadequate ventilation and impaired oxygenation as seen in the interstitial pulmonary fibrosis and the gross obesity. Squatting. The squatting position is assumed by the cyanotic children, particularly those with tetralogy of Fallot. By squatting, the arterial resistance is increased, thus diverting the greater volume of blood to the pulmonary circulation for better oxygenation. Angina pectoris, discomfort in the chest and adjacent area due to the myocardial ischemia. They have been classified into four types. Grade 1, angina on severe exertion. Grade 2, angina on walking uphill. Grade 3, angina on walking on level ground. Grade 4, angina at rest. Stable angina. The site of pain will be retrosternal. Character will be constricting or a crushing type. The radiation will be across the chest, both arms and the shoulder, interscapular region, neck, jaw, fingers, and epigastric region. Duration. The exertional angina will last for 1 to 5 minutes. Emotion induced angina for 5 to 15 minutes. Any pain which lasts for a few seconds is not an ischemic in origin. Precipitating factors. It might occur due to exertion, climbing stairs, anger, excitement, or sudden exposure to the cold. Relief. It can be relieved by rest or taking sublingual nitroglycerin that relieves the pain. Anginal equivalent. These are the symptoms of myocardial ischemia other than angina, such as dyspnea, faintness, and the fatigue. These are precipitated by the exertion and relieved by the rest and the nitrates. Prince metal angina. These occurs during the rest and recur in a cyclic pattern of ST segment elevation and depression during an attack. Nocturnal angina. Angina occurs during the sleep at night due to the coronary ostial stenosis as seen in the cardiovascular syphilis. Unstable angina. It occurs at any time, even at rest, without obvious precipitating factors, and the pain lasts for several minutes. Pulse. It is a waveform that is felt by the fingers, produced by the cardiac systole, which transfers the arterial tree in a peripheral direction at a rate much faster than that of the blood column. Brachial arterial pulses is better felt, but conventionally the radial artery is examined. To assess the volume of pulses, the palpating finger should compress the artery with pressure just sufficient to obliterate it during the diastole. Thus, the artery can re-expand against the palpating finger during the systole. Other arteries, example the opposite radial, femoral, dorsalis pedis, posterior tibialis, carotids, subclavians, and the temporals should be palpated and compared for any delay or difference in the volume. The pulse is described under the following headings: rate, rhythm, volume, character, and the condition of the arterial wall. Rate. The normal rate in an adult varies from 60 to 90 per minute. A rate below the 60 per minute is called as bradycardia, and above 90 per minute is tachycardia. Rhythm. Normally, the pulse is regular except for a slight increase in rate on inspiration and slowing on expiration. An irregular pulse may be regularly irregular in ectopic beats or irregularly irregular in multifocal ectopics or atrial fibrillation. Third, volume. It is an amplitude of pulse wave as judged by the palpating finger. It depends on pulse pressure and it is graded as I, normal, small and poor. High volume pulse. This is caused by the leakage of blood, high output states or increased stroke volume. Low volume pulse. Here, the amplitude of the pulse wave is small. This is due to the low systolic pressure or raised diastolic pressure or both. It is caused by the low stroke volume like all the stenotic lesions, cardiogenic shock, tachycardias, dilated cardiomyopathy and the heart failure. Varying volume pulse. Pulse alternance is a regular pulse, whereas the pulsus paradoxus is an exaggeration of the normal phenomenon of a low amplitude pulse during the inspiration and better amplitude during the expiration. Condition of arterial wall. This is appreciated by rolling the radial artery with fingers against the underlying bone. In young persons, it feels soft and elastic, while in elderly, it may be hard and tortuous. Comparison of other arterial pulses. Delayed and lower amplitude femoral artery pulses compared to the radials could be due to coarctations of aorta, aorta arthritis, or the saddle embolus. Blood pressure. This is the pressure at which the blood is flowing in the arteries. It is due to the pressure exerted by the intravascular blood column laterally on the vascular wall. Systolic blood pressure depends mainly on the cardiac output and diastolic blood pressure depends mainly on the peripheral resistance. Types. Isolated systolic hypertension. Here, the systolic blood pressure is greater than 140 mmHg and the diastolic blood pressure is less than 90 mmHg. It is commonly seen in the old age people. Accelerated hypertension. A significant increase in the blood pressure over the previous hypertensive levels associated with the evidence of the vascular damage on the fundoscopic exam. Malignant hypertension, a triad of BP of 200 by 140 mmHg, grade 4 retinopathy and renal dysfunction. Hypertensive urgency is the BP is markedly elevated without any evidence of end organ damage, whereas the hypertensive emergency is the BP is elevated with some evidence of the end organ damage. Jugular venous pressure. It is expressed as the vertical height from the sternal angle to the zone of transition of distended and collapsed internal jugular veins. The right internal jugular vein is selected because it is larger, straighter and no walls. It is situated between the two heads of the sternomastoid. Jugular venous pulse. It is a reflection of the phasic pressure changes and consists of 3 positive waves and 2 negative trough. Clubbing. It is the changes in the areas under the toenails and the fingernails that result from the chronic low blood oxygen levels. This is usually classified into the 4 grade. Mild. Obliterations of the normal angle between the nail and the dorsum of the finger. In moderate, there will be a additional longitudinal curving of the nails, whereas in severe, drumstick appearance of the terminal phalanges due to the swelling of the soft tissues. In gross, additional to the severe clubbing of the finger and the toenails, there is a thickening and enlargement around the wrist and ankles due to the thickening of the distal end of the bones. General examination. Examination of precordium. The term precordium refers to the aspect of the chest which overlies the heart. The angle of Lewis corresponds to the second costochondral junction. Traditionally, the precordial examination is carried out under the following heads. Inspection. Look for the precordial bulging which is seen in the long-standing cases of cardiomegaly or pericardial effusion. The apex beat is the lowermost and outermost point of the cardiac impulses and it is formed normally by the left ventricle. Look for the right ventricle pulsations in the left third and the fourth intercostal spaces in the parasternal area and in the epigastric region. Pulsations of a prominent pulmonary artery are visible in the left second spaces parasternally, and then those of the aorta in the suprasternal notch or sometimes in the right second spaces parasternally. Palpation. Palpate and define the apex beat. This is best done by the flat of the palm and accurately localized with the tip of the middle finger. The apex beat is normally localized in the left fifth intercostal spaces 1 centimeter inside the left midclavicular line. Ascertain the character of the apex beat and feel for a thrill. The thrill are the palpable vibrations corresponding to the loud murmurs. One may occasionally feel a loud opening snap or a third arch sound. A tapping or a slapping apex beat, which is a characteristic of a mitral stenosis, is an ill-sustained, low-amplitude apex beat. It represents a palpable, loud, first arch sound. An abrupt, forceful or hyperkinetic apex beat is an indicator of diastolic overload type of left ventricle hypertrophy. A sustained heaving apex is a suggestive of a systolic overload type of left ventricle hypertrophy as seen in the aortic stenosis, hypertension and coarctations of the aorta. The apex may not be palpable if it is lying under a rib and in emphysema or obese persons. Second, feel for mid-precordial right ventricle pulsations or a heave in the left fourth space in the parasternal plane. A sustained powerful heave indicates the systolic overload type of right ventricle hypertrophy. An abrupt, forceful and hyperkinetic pulsations indicates the diastolic overload type of right ventricle hypertrophy, example tricuspid incompetence. Third, feel for the pulsations in the left second space. These are the indicator of enlarged pulmonary artery. Aortic pulsations due to the aneurysmal dilatations or unfolding of the aorta are appreciated in the suprasternal notch and the right second spaces. In pulmonary hypertension, a loud pulmonary second sound is palpable as a diastolic shock in the pulmonary area. Percussion. First, percuss the left border of the heart, starting from the left anterior axillary line and proceeding medially with the pleximeter finger kept parallel to the left border. Defining the right border formed by the right atrium is difficult unless there is a gross enlargement of this atrium. Percuss over the left second space and the right second space parasternally for a dull note in cases of pulmonary artery and the aortic dilatation. Finally, auscultation. This is done over the mitral, tricuspid, pulmonary and the aortic areas. The mitral area overlies the apex beat. The tricuspid area is over the fifth intercostal spaces just left to the sternum. The pulmonary area is over the left second space along the lateral sternal border, and finally the aortic 1 area is over the right second space along the lateral sternal border, and the aortic second area, that is the Herbst area, is over the left third space parasternally. Thank you.